With the treatment of respiratory diaphragm, we want to make sure that our patient is lying supine and close to our side of the table, and we want to be facing the head of the table also. Now remember that with respiratory diaphragm, we have to locate that rib 5. Now if we find the costal margin and we gently follow that up to the xiphoid process, that's about rib 5, rib 6. So it's a perfect position for us to lock our thumbs and our index fingers and our hands around the anterior and lateral aspect of that rib cage. Now remember I had talked about in the anatomy portion of this section that we really wanted to take full advantage of coming into contact with the full structure. Well, we do that by coming anterior with our thumbs, laterally with our hands, and then the table acts as a reinforcement so that we engage the posterior aspect of the diaphragm also. With this technique, there's a risk in that a lot of people like to press their thumbs in. We don't want to press the thumbs in. There's a xiphoid process here. We don't want to cause any type of injury to that tissue. So we really just want the majority of our pressure to be coming from this aspect of our index finger and our thumb, or the thenar web. If you find that you don't have the dexterity to grab as wide of a surface structure, then you can come in with your thumbs onto the sternum, with your hands more in this sort of a position, so that we are right at that 5th rib attachment for the respiratory diaphragm. In treating the diaphragm, we want to disengage and exaggerate its dysfunctional position. So we need to assess through palpation, very subtle, specific, and precise palpation, to see if you can feel one lung engaging before the other. You really want to get a sense to see if one side of the diaphragm is firing before the other is. And it's very quick. If you blink, you'll miss it. You really do need to be focused and present with your patient's respiration to get a sense of which portion of the diaphragm feels like it's engaging first. And with her, it feels like her left side is engaging just a fraction of a second faster than her right side. So to treat respiratory diaphragm, we like to shorten its position in all available ranges. We like to see what its permitted motion is like through this thoracic cage. And then we like to bilaterally load down to the table, up towards their cervical spine, and then gently engage one hand medially, engage the other hand medially. This starts out as a direct technique and very quickly becomes an indirect technique with that tissue slackening, becoming a little bit more elastic. We're really shortening the position of this tissue, and it's going to be a little challenging for our patients to breathe diaphragmatically. You should instruct them that they should be breathing a little bit more apically. Now, if you can feel a pulse, you're probably feeling the cardiac rhythm. Remember that the respiratory diaphragm is intimately connected to the mediastinal tissue and the pericardium. To give you a sense of just how connected this tissue is to the thorax, the shoulders, and the cervical spine, what we're going to have our patient do is rotate her head to the right. As she rotates to the right, so does the respiratory diaphragm. Remember that we have esophagus that runs through esophageal hiatus of the respiratory diaphragm, and that we can, in a direct technique, influence a change in the environment, slowly bringing the diaphragm more back to a neutral position. Once here, we sit and wait for a decrease in tension, a decrease in densification, an increase in elasticity to the tissues. When that happens, it should feel like it's less of a challenge to hold this tissue in this position. It's very easy for me to hold this position now, so I'm going to get her to rotate her head back to neutral. There's no change in the position. And now what we're going to do is have her rotate her head to the left. And now you can definitely see that there's an involvement with cervical spine, range of motion, and the respiratory diaphragm. So now, with another direct technique, we encourage this respiratory diaphragm back to a neutral position. We wait for a change in the environment to take place. Wait for an increase in elasticity, a decrease in tension, a decrease in densification to occur. Again, when that tissue has done making the change, it should feel very easy to hold the respiratory diaphragm in this position, which it feels right now. We're going to have her rotate her head back to neutral. And once back in neutral, there's an even increase in softening to this tissue. I'm going to give it a little assessment for pliability. I definitely have more pliability into this area. And now what I'd like to show you guys is the involvement it has with the shoulders. So holding this respiratory diaphragm in this neutral position, I'm going to have her very slowly with her right shoulder try and bring her arm above her head. As you can see, the shoulder through serratus and fascial tissue is connected to the thorax. Obviously, it increases the angle of which that respiratory diaphragm has to function. So I'm going to gently, in a direct technique, bring that respiratory diaphragm back down to a neutral position. And we're going to sit and wait here for this environment to change. Remember that this is a slow technique. It takes time, and it will take a series of treatments before you can see long-lasting treatment effects, especially in patients that have had chronic shoulder injuries. It's becoming easy for me to hold this respiratory diaphragm and thorax in this position. So let's have her bring her arm back down. And we'll do the same with the other side. This side moves a little differently. So I'm going to engage the thorax into the respiratory diaphragm a little bit more on her left side. Wait for a change to take place. Now there's an increase in elasticity and a softening in through the tissues. It's becoming easy for me to hold this position. We'll have her bring her arm back down to neutral. We will reassess pliability. There's a lot of elasticity in through this tissue now. To end the treatment for respiratory diaphragm, we're going to have her take a deep breath all the way in, and then all the way out. As she exhales all the way out, we're going to take up the slack a little bit, and then inhale again, and all the way out. Take up the slack one last time, and then inhale all the way in and out. Now, with some patients, sometimes they're of a larger size, and their size doesn't permit us the ability to make this type of contact with their thorax, with their respiratory diaphragm. If you have patients that are like that, then my suggestion to you is to treat unilaterally. You're going to treat from one side, where your one palm comes into contact with the full lateral and anterior aspect of that thoracic rib cage, and where the respiratory diaphragm is up at that rib 5. Very gently, we are going to load medially and down to the table. We perform the exact same techniques as what we did in the previous section, with rotations of the head and with forward flexions of the shoulder. When you've finished treating one side, then you come around to the opposite side of the table and you do the exact same treatment technique. And that is how I like to specifically and precisely treat respiratory diaphragm as it pertains to shoulder dysfunctions and cervical spine dysfunctions.